Now we'd like to invite Dr. Regan to the stage. Dr. Regan, she was graduated from Galway University with honors. Then she became a consultant in obstetrics and gynecology, and she obtained her fellowship and subspecialty in maternal fetal medicine from Pennsylvania. She's a senior lecturer at the RCSI, and she has special interest and expertise in medical problems in pregnancy. She would like to talk to us tonight about intrauterine growth restriction.
Thank you very much, and thank you, Ayad, for inviting me to Jerusalem to speak to this august audience. And when you asked me what I'd like to speak about, I really didn't know what I should talk about, but it so happened that I was reviewing the national guidelines on fetal growth restriction, and also I was looking after a relative, which is not a very good idea, who happened to have an extremely small baby, which I managed to get to 35 weeks. So it was something that was in my mind, and I thought it was something that is common and applicable to all of our practices and really very important. So I need to go back. So I want to talk initially about the impact of fetal growth restriction, and I suppose then I want to talk about how we identify the small fetus and whether a small fetus is in fact small, just simply small, or is in fact growth restricted. And then I suppose to talk about what is the difference between early and late onset fetal growth restriction and its implications, and how best to optimize care. And so when we identify a baby that's small, and that's defined as a baby that measures less than the 10th percentile from an estimated fetal weight point of view or from an abdominal circumference point of view, we have to consider that there are multiple etiologies. And the first thing you should do, and we should all do this, is ensure that there's adequate dating. We date all our pregnancies in the first trimester, and that helps to prevent us over-diagnosing small for gestational age, or indeed not diagnosing it. Importantly then, in the second trimester is the fetal anatomy scan, because that's when we get to look at the baby and exclude fetal malformations. And that's a really important thing, because many small babies will actually be anatomically or genetically abnormal. The other part that's important when you're teasing out whether this is actually a placentally driven disease is to look at other features which may be impacting. Smoking is a very common practice in our country. Approximately between 8 and 10% of women smoke, and these babies are very small. In addition, there would be maternal medical conditions which may cause a small baby, and there are other nutritional and social deprivation issues which can relate to a small fetus. But the ones that we're really interested in are the placental causes of fetal growth restriction. And these are the ones that are important because they are associated with an increased morbidity and mortality in the fetus. So fetal growth restriction, which is related to placental abnormalities, has an increased risk of stillbirth and neonatal death, adverse perinatal outcomes, adverse neurodevelopmental outcomes, and a risk of adult disease. And the most important thing we can do in order to manage these cases properly is to recognize these abnormalities in advance of And so recognition in terms of our antenatal care is key to improved outcome. And so when we talk about stillbirth, the risk of stillbirth is about 8-fold if it's unrecognized in fetal growth restriction. And we know that with a small baby born at a certain gestation, its outcome will be worse for a baby born prematurely but not fetally growth restricted. And so Gardozzi did a very nice look at the outcomes for all babies, ones without fetal growth restriction and the ones with fetal growth restriction, and found that if you identified fetal growth restriction and managed that baby appropriately, you could reduce the perinatal morbidity or mortality. But in fact, if that case went undiagnosed, then the perinatal mortality or the stillbirth rate approached 2%. So it's really important that we identify these babies. And so we have fetal consequences of being small, and that is stillbirth. And obviously, there's the risk then of preterm delivery of babies that are identified as being small. And if they're very low birth weight, that's an independent risk factor for these babies. in the neonatal period, they can have necrotizing enterocolitis, respiratory distress syndrome, neonatal encephalopathy, and neonatal death in the neonatal period. And in the infant period, they've an 8-fold higher rate of cerebral palsy, chronic lung disease, and neurodevelopmental disease. They also suffer with behavioral problems and learning difficulties. And in adult life, we now know that that babies who are growth restricted have metabolic syndrome, which is associated with advanced atherosclerosis, ischemic heart disease, stroke, and hypertension, and diabetes. And so in all, it is the single largest contributor to perinatal mortality in non-anomalous fetuses, and so therefore it's very important. In addition to that, how growth restricted the baby is very important, and we find that below the 3rd percentile is the group that is at highest risk of stillbirth. And so how do we define a small baby? Well, traditionally we've said less than the 10th percentile, but that's an arbitrary cutoff. So less than the 10th percentile will not identify all babies. Will identify most babies that are growth restricted, but in fact 80% of those babies will be appropriately grown. So it's an arbitrary definition in a heterogeneous group of women. And there are inaccuracies around the measurement, and the use of customized fetal growth charts do improve our pickup rate, but only 20% are truly growth restricted. And in addition, we need to differentiate the difference between early onset growth restriction and late fetal growth restriction. That's because they have differences about them in terms of the pathophysiology and outcome and the screening for them. So in the past, we've looked at growth restriction from a placental point of view, and the feeling was that asymmetrical growth restriction was related to poor placental perfusion, that there was head sparing. That meant that the baby's head growth was normal, but the abdominal circumference was small. Symmetrical growth restriction was often considered to be genetic in origin, or in the case of very early onset growth restriction, all parameters were small. And I suppose we're going to talk a little bit more about how we tease that out a bit further. So the condition that's associated with early onset fetal growth restriction is that is associated with placental pathology. So how do we diagnose a small baby? Well, in fact, our overall detection rate clinically is quite poor. So symphysiofundal height will detect about 30% of small babies. And if we actually measure the symphysiofundal height and plot it on a chart, that improves our detection rate to about 50%. But as I've said, if we don't detect the small baby, the risk of stillbirth is increased 8-fold. So it's really very important. Studies have shown that if we do ultrasound at 28 and 36 weeks, we'll obviously improve detection. But that's a high resource modality, and it's not something that we can afford in our hospital. There is the potential to screen at-risk patients. So again, you would look at the past history. If there's a previous history of small for gestational age, if the woman is a smoker, has hypertension, then you might pick up more of the small babies, but we still miss a lot of them. And then what's the best way to detect a small baby? What is the best measurement? We measure biparietal diameter, head circumference, abdominal circumference, femur length, and generate estimated fetal weight. But in fact, the abdominal circumference is the best discriminator of a small baby that there is, with a sensitivity of almost 80%. The other ultrasound modalities that we can use are the Dopplers, and they're very important. Dopplers are particularly important in early onset growth restriction because they identify uteroplacental malperfusion. And we know that when the placenta embeds, and it embeds poorly, the trophoblasts do not invade the spiral arteries, and there is an abnormal uterine blood flow. And the first indicator of that is an abnormal uterine artery waveform, and then downstream the fetus will adapt and have an abnormal umbilical artery Doppler flow. Later, when the fetus becomes hypoxic, this translates into an abnormal MCA Doppler, which relates to cerebral blood flow, and even later the ductus venosus Doppler becomes abnormal. And we'll talk a little bit about that in a moment. So in order to, I suppose, standardize the definitions and optimize the management and improve comparisons between research, a group of experts met in 2016 and developed a consensus around what early and late onset fetal growth restriction was, and this is known as the Delphi consensus. And essentially, the Delphi consensus said that you had early onset fetal growth restriction if it was diagnosed before 32 weeks, and that this was characterized by a spectrum of abnormal Dopplers that involved umbilical artery, middle cerebral artery, and ductus venosus alterations, and that usually reflected poor placental function and was associated with a high perinatal mortality rate. In contrast, late onset fetal growth restriction happens after 32 weeks. It is usually more associated with MCA Doppler abnormalities, and it is associated with a lower perinatal mortality rate, but often is associated with neurodevelopmental impairment. So we have early onset fetal growth restriction is driven by the placenta, there's malperfusion, we get abnormal Dopplers, changes in the umbilical artery to MCA ratios, and a late adaptation in the fetus, which results in hypoxia, absent flow, abnormal ductus venosus Dopplers, and reverse flow. And in addition to that, there are parameters that we can measure which are physiological, which include the CTG and short-term variability and an abnormal biophysical score. So just to talk a little bit about how we can monitor early onset growth restriction, because this is the one associated with severe morbidity and mortality. We can use growth and Dopplers, and obviously we use centile charts. We measure growth on a 2-weekly basis and look for interval growth. We look at the abdominal circumference, we check femur length and estimated fetal weight. But also we have the CTG, which is an excellent tool for detecting fetal hypoxia. A normal CTG practically outrules fetal hypoxia. And we know that the loss of short-term variability is the important thing, that very, very straight line with shallow scallops that you see with a really hypoxic baby. That flattening is called reduced short-term variability. The problem with that is that it's quite objective. And so computerized CTG has been shown to be much more useful in predicting fetal acidosis than regular observation of a CTG. The biophysical is very useful, but it's not very predictive. It's useful in the moment. So you can know from a biophysical score, which is looking at tone, movement, breathing movement, amniotic fluid volume, how the baby is at that time. And a score less than 4 or 2 is significantly abnormal and should prompt delivery. And you can also use that in tandem with the CTG. So we have other modalities to look at these babies. And I suppose our more sophisticated Dopplers look at the ductus venosus Doppler as well as looking at absent and reverse flow in the umbilical artery Doppler. And we understand the ductus venosus responds to hypoxia by dilating, and it increases blood flow to the heart. And when the heart becomes decompensated, if you like, due to increased afterload, there's increased intraatrial pressure, and we see that as a reversal of flow in the ductus venosus, and that's a late finding and should prompt delivery. So just to go back a little bit to talk a little bit about how we know that. So the Truffle trial was a trial conducted across many centres between 2004 and 2008, and it was a very interesting trial. It looked at fetuses between the gestational age of 26 and 31 and 6 weeks. They were randomized to 3 different arms, which included use of ductus venosus, computerized CTG, or a combination of these. And they looked at outcomes which were death or neurodevelopmental delay beyond 2 years. And what they found, and in this study they used computerized CTG, so that's not a modality that's available to everybody, and that's the problem with this study, I suppose, because they found that the best predictor of outcome, of improved outcome, was computerized CTG in tandem with the ductus venosus Doppler in order to time delivery in these babies. They also found that gestational age at entry and birth weight strongly related to adverse outcome. So I suppose arising out of that, if computerized CTG is not available, then the best, markers to prompt delivery would be the regular CTG and the ductus venosus Dopplers. And we haven't really moved very far from that at this stage. And so our protocol, and probably everyone's protocol for early onset fetal growth restriction, is predicated by Truffle. And in fact, the Truffle trial showed that in following protocols, outcomes could be improved. So their stillbirth rate was 2.4%, which in over 500 babies of that gestational age was incredibly good. And so we know that the protocols involve increased surveillance, and that's what we should be doing with these babies. But bear in mind that even with a stillbirth rate of 2.5% in truffle, there were 12 stillbirths. 5 were because of withdrawal of 5 were due to parental decisions about managing the baby by delivery, and 7 were unexpected. So even with intensive monitoring in these babies, babies will die. Our algorithm then arising out of truffle is for babies that are less than the 10th percentile with increased umbilical artery Dopplers. They will have screening every 2 weeks. They will have Dopplers weekly, and then monitoring can be intensified as required. If the Dopplers become more abnormal, if they become absent or reversed, then they would be counselled regarding delivery. If they're very preterm, or they will be monitored according to the CTG and the ductus up to 30 weeks for reverse flow and 32 weeks for absent endostolic flow. So we're going to talk a little bit about late fetal growth restriction, a bit of a different pattern. The middle cerebral artery is the marker really of late onset growth restriction. It reflects a dynamic between the vasodilation in the fetus in response to hypoxia and the placental impairment, and it is much more subtle. So what we tend to use in that situation is the ratio between the MCA PI and the umbilical artery PI. And when that falls below 1, that baby is in trouble. So why does the MCA PI matter? Well, it's a response of brain sparing. So normally there's a high resistance circulation within the fetal brain, but when in response to hypoxia, there's vasodilatation that falls, and that's a sign that there is redistribution of blood to the brain, to the coronary arteries, and to the adrenals. So the DIGITAT study looked at timing of delivery in late onset growth restriction, and this was a Dutch consortium, and they looked at induction versus expectant management in over 600 women, and they didn't find any difference in outcome. And all these babies were between 36 weeks and term, and they were thought to be less than the 10th percentile. They didn't find any difference in outcome unless the baby weighed less than the 3rd percentile, and we've already said that's a marker for severe growth restriction. However, they did find a reduced incidence of preeclamptic toxemia and low birth weight in the induced group, and arising out of that, and the general consensus now would be that our general recommendations would be if your birth weight is less than the 3rd percentile, the stillbirth rate remains at 1%, deliver by 37 and 6. If the umbilical artery PI is over the 95th centile, deliver by 36 and 7. And if there's an altered CPR, cerebroplacental ratio in term, deliver by 39 weeks. So what about the future and optimization of care? Well, I suppose we can modify the risk factors. We can advise re-smoking cessation. That's the single most modifiable behaviour in relation to fetal growth restriction. And smoking remains a leading cause of stillbirth, with a 1% rate of stillbirth in smokers overall. We can treat hypertension, and I would say that in truffle, one of the big impactors on outcome was the co-presence of hypertension, and obviously there's an overlap between preeclampsia and fetal growth restriction. Low-dose aspirin in placental disease, it's obviously has some impact on circulation, and it does improve outcome if you can identify the women who will develop fetal growth restriction. We know that for antiphospholipid syndrome and for certain thrombophilias, aspirin and low molecular weight heparin can help prevent fetal growth restriction. Into the future, therapeutic strategies might be the use of biomarkers such as PLGF or SFLT1. Sildenafil has been looked at. It's a vasodilator, and growth factors are also potential future targets. But what about us? Well, our interest in the COOM is in smoking and pregnancy. We've done some work on it. We developed a randomized controlled trial of an intervention which was a clinic for smoking cessation, which had a smoking cessation therapist, a midwife, and a team that looked after these women. We ran into COVID, but we did have an outcome. We looked at over 400 women, and the women who were in the smoking cessation clinic had improved rates of smoking cessation and improved birth weight. Following on from that, we became interested in vaping, because vaping is now the new thing, and it's obviously very common. The problem with vaping as opposed to nicotine replacement is vaping is like nicotine replacement on steroids. People vape a lot, and they vape a lot of stuff, and we don't even know how much. We do know that nicotine affects the fetal brain. Our research, we did a little retrospective study, and we found that growth is not as impacted by vaping mothers. So women who vape don't have babies that are as small. As smokers, they're more like the normal, but we don't know what nicotine is doing to the developing brain. So we've received a grant from Science Foundation Ireland to look at the outcomes in women who vape or smoke in pregnancy, look at their obstetric outcomes, their infant neurodevelopmental, nutritional and psychological outcomes over a 4-year period. So we will await and see the outcome of that. I just want to finish by saying thank you so much for inviting us to talk today. Thank you.
Thank you very much, Doctor.